Okay, Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. This is Dr.Deepak Kumar from the Institute of Manual Therapy, and today I've been allotted 20 minutes to start to give my lecture. That is the bad feet is equal to bad spine. Dare to think beyond the. I'm sure many of you must have how to change this slide. I'm sure many of you must have seen the film of the MRI film of the patient. Or the patient might have come to you with his or her MRI film and thinking the pain is coming because of the disc prolapse. And many times patients do get operated, okay? Or you keep treating them for the back pain, for the spine, still the patient did not respond because the pain was not coming from the spine. And this is what the research by Dr. et al., which was published in American Journal of Neuroradiology in November 2014, which said it is okay to have disc prolapse, it is okay to have degenerative changes in the spine, it is okay to have spondylolisthesis. Many people do have it. That does not mean that it starts giving pain to all of them. That means maybe the pain coming not only from the spine, but patient might be getting pain in the spine, which is originating as could be the wrong alignment of the spine, that could be the foot, that could be the knee. And today we are going to discuss how the wrong biomechanics of the knee joint can spoil your spine. Wrong biomechanics of the foot can spoil your spine. This is what we are going to discuss. So for that, obviously you must examine your patient globally as well as locally. We are doing the local examination, right? We do the segmental examination of that particular vertebra, we do the radiological examination, we do check the passive exercise movements and all those things in the spine. But not all the physios, maybe many of you do that, but not all the physios examine the complete chain. That is the foot, knee, and the sacroiliac joint as well as the hip joint. So this is what we are going to discuss in this presentation, that you must examine your patient globally as well as locally. And this is what my topic is, bad foot is equal to bad spine. How does bad foot affect your spine? This is what we are going to discuss. Before doing that, we must know the biomechanics of the foot. So non-weight bearing. So let's talk about the foot. The non-weight bearing, this is how the foot goes into pronation. Okay? So foot goes in slide, dorsiflexion, eversion, and abduction. However, for the supination, when it is a non-weight bearing, the foot should go slightly inversion, okay, plantar flexion and abduction. But in case the foot is resting on the floor, there is the talus which has to go down and in for the pronation, and the talus has to go up and out for the supination. And as you can see, this tibia and fibula, which is resting on the talus, okay? And if the talus is going 1 degree in and out, then the tibia and fibula will also go 1 degree in, and if the talus is going out, the tibia and fibula should also go out. So it behaves like a mitral hinge. So if the mitral hinge, one hinge moves 1 degree, the second will also move 1 degree in the same direction. So and it is okay to have supinated foot or the pronated foot. The problem comes when you have over-supinated foot or over-pronated foot. So this is the animation, like if the talus goes down and in, the tibia and fibula will also move down and in, and if the talus goes up and out, the tibia and fibula will also go up and out. And as I said, we need to have supinated foot as well as pronated foot, because supinated foot is a rigid foot, and we need rigid foot while walking during the push-up phase. And we need loose pad foot, that is pronated foot, for the mid-scan foot, because it works like a shock absorber. Okay, so we need supinated as well as pronated foot. The problem comes when it is over-supinated or over-pronated. Majority of the patient, in my experience, have over-pronated foot. So when they have over-pronated foot, this is what we expect. If the foot is over-pronated, the tibia and fibula will rotate medially, and that will give valgus strain and hyperextended knee as well as the pain on the medial side, on the medial meniscus. If the tibia and fibula is over-internally rotated, even the femur will get overly internally rotated. That will give bursitis as well as tightness of the hip flexors. And when the hip flexors get tight, the glutes will get weak, psoas will get tight, and you will get hyperextended lumbar spine. Okay? So the flexors are tight and the back extensors are tight. So glutes will become weak and the abdominals will become weak. And your entire growth pattern will be affected, which I'm going to discuss in a very short while. As I said, it is okay. This is what is normal foot. And the best position, which rarely anyone has. Either someone is having slightly pronated foot or slightly supinated foot. And it is okay, as far as the variation is a little bit. The problem comes when it is over-pronated, okay, or it is over-supinated. That is what the problem is. So, how to check that and what are the clinical implications of these two, this is what we are going to discuss. So, a very simple test when you want to check if it is over-supinated or pronated, you stand behind the patient and you will see if it is over-pronated, you will see the convexity of the tendon Achilles, you will see on the medial side. But if it is over-supinated, you will see the convexity on the lateral side. In case of over-pronated foot, you will also see too many toe syndrome. Means instead of seeing one or two toes, you will be able to see three or more toes if you are looking from behind. At the same time, if you put your hand with the equal distance here, you will see the medial malleus touching with your palm. However, in normal foot, it will be equal distance on both sides. And if you look at the feet of the patient, this is how the normal wear and tear of the sole of the foot will be. But in case someone is over-pronated, obviously, then the medial side will get more erosion, and in case of over-supinated, it will be the lateral side, which everyone knows. So I won't be giving more time on this slide, but yes, what are the implications? This is what will happen, not only in the spine, but also the pain in the knee joint will be there. Why and how a person will get this knee pain? This is the chain reaction. Because of the over-pronated foot, the tibia and fibula will be internally rotated, resulting in the femur also getting too much internally rotated. And if the femur is too much internally rotated, you get tight anterior hip structure. That will lead to poor gluteal control, increasing pelvis force, and lateral tracking of patella. Obviously, when the femur goes in, the outer structure, which is on the outer side, will get tightened up. And if they are tightened up, they will pull the patella laterally, and the person will get knee pain, because the lateral tracking of patella will also retain not only the cartilage or the erosion of the cartilage, but also it will irritate the fat pad. And we all know the fat pad is highly innervated. So even if you keep giving strengthening exercise to vastus medialis, it will not help because the femur is internally rotated. Next could be, again because of the pronated or over-pronated foot, I should say, internal rotation of the femur, that will increase the pelvis force and hence the lateral tracking of the patella, and that may also lead to tight lateral structure. Not only the tension fasciolata, but also the lateral retinaculum of the patella. So we need to see if the patella is shifted or tilted or both. And in case it is there, either both or any one of them, we have to release that lateral tracking of patella also. This will also lead to tight hamstring, especially the lateral head of the gastrocnemius. I'm not talking about medial head, especially the lateral head of the gastrocnemius will get tight. That will lead to pronation, increase valgus force, and hence increase the lateral tractor patella. And in the last, which is not the very common, but we see this as very, very common. Majority of us, we concentrate mainly on vastus nivalis obliquus. However, there are so many other factors responsible for giving patellofemoral pain to the patient. So make sure we take care of that. And in case of long-standing case, this may be evident even in case of X-ray. So when you take the merchant view or the skyline view, you will see the patella slightly shifted as well as tilted laterally. So obviously there will be extra erosion of the cartilage and the fat irritation. So not only the spine, but even the knee joint will give pain. Now why the spine will be affected? Because of the bad foot or the over-pronated foot or over-supinated foot. As we all know that in the gait we have the stance phase as well as swing phase, which is 60 versus 40. I'm not going to teach you this gait. You all know gait very well, but I'm going to teach you the clinical implication of the over-pronated foot with the help of gait. So when we do the heel span, the foot has to be supinated. As I told, that we need supination as well as pronation. So the foot has to be really rigid so that it can absorb the shock. And when we go into the mid-stance position, the tibia is anterior, tibia is posterior, and the soleus has to contract eccentrically to allow our foot to come into the pronated position, so that it works like a shock absorber. But in case it goes into overpronation repeatedly over the time, the tibia and tibia moves internally, hence the femur, and then there is a tightness of the flexor. Now, during the push-up phase, if you see there is an extension at the hip joint we require, and if there is a tightness of the hip flexor, obviously this extension will be restricted, and instead of having this extension, the person will try to rotate the pelvis, okay? He will rotate the pelvis, and if in case he is rotating the pelvis, there will be extra rotation of the sacroiliac joint as well as the facet joint arthropathy one will have, and maybe the trochanteric bursitis also. So this is why, because of the overpronated foot, you will have interrotation and then the tightness, and then you get the facet joint arthropathy as well as the sacroiliitis. And the story does not stop here. There is further more to it. Okay? In addition to this overpronated foot, even the supinated foot or the rigid foot is also not good. Now, look at this. At this position, when we go to from mid-stance to the terminal stance, here we must have some amount of dorsiflexion. At least the 4 degree of, at least 5 degree dorsiflexion is mandatory. And if this 5 degree of dorsiflexion is not there, if the person is having restricted ankle, you will have bouncing gait, okay? Because the proper push-up will not be there. You will have the bouncing gait, or the person will do over-rotation of the foot. And that will again give compression forces on the disc on either side, and person will have back pain again and again. In addition to this, when we go for the toe-off phase, if you notice here, the toe is almost 90 degree extended. And how much is minimally required? 30 degree. So one must have at least 30 degree of toe extension, so that the gastrocnemius and the tensor and the fascia, plantar fascia, which is a continuation of the gastrocnemius, then that fascia must get stretched. Okay? And if it is not getting stretched, the recoiling, the momentum will not be there. Elastic recoiling will not be there. Inertia will not be there. You know, from this phase up to the mid-swing, the leg comes because of the elastic recoiling. And if the push-up phase is not effective because it is not getting strength, because it is not getting long, the muscle has to work, person has to bring the leg. Otherwise, up to mid-swing, let's talk about up to mid-swing. From this push-up up to mid-swing, the leg comes automatically because of the elastic required. Okay? But if this stretch is not there, person has to contact the plexus of this leg constantly. concentrically and carefully, actively person has to contract these muscles of this leg, and then the person get hip pointer of this leg because the flexors are overworking. I am talking about the leg which is in the swing phase. Are you getting it? So up to the mid swing, the leg should come automatically because of the elastic recoiling. But if there is no stretching of the plantar fascia as well as the gastrocnemius, the push-up phase will not be effective, and person has to contract the hip flexors, and again you get the tightness. So it is important to have effective dorsiflexion at least 5 degrees. It is mandatory to have effective extension of the great toe, that is minimum 30 degrees, and your tibialis anterior as well as your soleus and adductor hallucis brevis has to work effectively so that your foot should not go into over-pronated position. At the same time, if the person is having a rigid foot, the ground direction forces will be so much if the person is not able to pronate it in mid-stance. The peroneal tendons will get tendinitis, and person may get stress fracture also in that. And that person may get emergent injury, that is ankle sprain. So it is important to have healthy mobile foot, not over-pronated, neither over-supinated. Okay, so as I said, you also need to have 4 degrees of pelvic tilt during the gait. So make sure you check the abductor muscle, that is gluteus medius for the gait. And as I told, the great toe must move at least 30 degrees. And if the stiffness is there in the great toe, you will have the shorter stride length, low gear push-off, circumdactory gait, and a propulsive gait. As I told you, it is the windlass mechanism because it was discovered by windlass. It's stretching of the plantar fascia during the push-off phase. So, okay. So this is what is, if there is over supination, improper heel stride will get in an everted position that will disrupt the natural load and recoil of the foot, and person will have pain, medial joint pain, shin splint, tibialis posterior tendinitis. Now what to do? What is the treatment for that? Treatment will be, make sure you give strengthening exercise, stretching exercise to the gastrocnemius, peroneal muscles, and tensor fascia lata muscle. Stretching exercise. And you must give the strengthening exercise to the tibialis anterior, tibialis posterior, and the soleus plus the gluteus medius and the maximus. And if somebody is having over-supinated foot, in that case, the person may get ankle sprain, as I told you, and the peroneal tendinitis. So make sure you give stretching exercises to the inverter and the strengthening exercises to the everter. So for the early heel lift, make sure you make the ankle mobility. At least how much degree I said? Minimum 5 degree of dorsiflexion is important. Otherwise, the patient will have bouncing gait, like an ostrich. Patient will jump while walking, and that will give unnecessary compression to the disc, as well as the sacroiliac joint, as well as the spine. Check the hip flexors. If they are tight, you will have too much of rotation of the pelvis. That will again give strain to the sacroiliac joint, as well as the facet joint of propathy. And of course, you must check the gluteus muscle also. So when you get the back pain case, make sure you examine your patient globally as well as locally. Check if it is over-pronated foot or over-supinated foot. Check for the tendo-Achilles from behind. Check for too many toe syndrome. Check for any callus formation on the medial side of the great toe or the heel, or the lateral side of the little toe and the heel. And check for the navicular drop. Check for the callus going down and in. So make sure you examine the foot. Make sure you check the position of the patella. Make sure you check over-rotation of the tibia and fibula and the femur. And if all of those things are there, I'm sure your patient will recover for the back pain also very nicely. So treat your patient as a whole. Just don't treat spine, just don't treat foot. Treat the patient as a whole. And this is what my small presentation, because the time limit was only 20 minutes. I hope I have completed in 20 minutes. And thank you very much. If there is any question or query, I'll be more than happy to take. Shukriya. Assalamu alaikum once again.
السلام عليكم يا دكاتره. دكتور فرج احكي صور. طيب دكتور فرج بس هو كان بيرحب بطلبه بتوع جامعه حورس، فانا برضو برحب بطلبه جامعه حورس، وبعدين برحب بطلبه جامعه القاهره يرفع اولادي من جامعه بدر، جامعة 6 أكتوبر، جامعة مصر، وجامعة MTI، الجامعة الصينية،